Good morning. My name is Salome Maswime. I'm an associate professor at the University of Cape Town. I'm an obstetrician and gynecologist, and I'm also the head of global surgery. Today, I'll be talking to you about managing pregnant women during the pandemic. And so I've looked at it from three different perspectives. One is discussing transmission and what has been found through with studies that have been done on transmission, looking at pregnancy outcomes, and then looking at the science behind COVID-19 and what has been done. And, some of the interesting points around transmission in many infectious diseases, when we study them in pregnancy, we're really concerned about mother-to-child transmission. But in COVID-19, unlike other pregnancy diseases or infections, we worried as well about the healthcare facility and transmission to other members of the family, healthcare workers, and everyone else that the pregnant women may come into contact with. In terms of outcomes, we're not only worried about patients with COVID-19 and how they do, but we're also worried about those that are negative and what the maternal and perinatal outcomes are altogether in pregnant women during this time. And then the last part is understanding the science. And so a lot of work has been done on placental science, on vaccines, on the disease as a whole, on health systems issues. And so what is important is for us to keep up to date with what's happening in the rest of the world. And I'll also present some of the research that I've been part of. So pregnancy during a pandemic, I think more than anything, it's understanding the fear that pregnant women have, one of attending antenatal clinics, of seeking healthcare, delayed diagnosis of pregnancy, etc. And so we need to be mindful that it's quite an emotional time for the pregnant women. And so there's a lot of anxieties and fears. And so as we manage them and look after them, we need to consider all of this and not only look at the disease aspects of it. And it's also a time of isolation. We're all aware that, in many hospitals, partners have not been allowed in some instances. There's been limitations on who you can allow into the antenatal clinic, who you can allow into the labor ward, and who can visit the women and the family members who are allowed to visit the friends. So under normal circumstances, you'd find that a pregnant woman has got visitors. People travel from far to come and see the new family member. But in this case, during a pandemic, all of that is impossible. And so I think, having spoken to a number of pregnant women, some of their most frustrating parts of being pregnant during this time is not so much the disease or the fear of disease, but it's going through the whole pregnancy experience on their own. And so we need to be mindful of that. And then the other thing is the fear about the pregnancy outcomes. Women are concerned, will I be okay? Could I get COVID? If they have COVID-19, will I transmit it to the child and or even to my family? And so there's a lot of fears and anxieties that one needs to address when you look at the pregnant woman and not only think about the disease. And so I took this quote from the Journal of Physiology. Besides the direct impacts of the disease, a plethora of indirect consequences of the pandemic adversely affect maternal health, including reduced access to reproductive health services, increased mental health strain, and increased socioeconomic deprivation. And so we need to this is really probably the core of what I want to talk about, that, as we think about COVID-19 in pregnancy, it's looking at how the reduced access to reproductive health services has affected pregnant women as a whole. And whilst we know that women are still supposed to continue attending antenatal clinic and seeking care, but not when women are afraid to attend, when women don't know whether they should attend or not, they might not choose the services that are actually there and accessible to them. And so you've got decreased utilization. I've already mentioned increased mental health strain. I'll go into it a bit more, but also just to touch on the increased socioeconomic deprivation and just think about how the past year and a half has affected us as human beings, as women. And so the pregnant women, just as normal citizens, have had the same challenges where they possibly, some have been retrenched, might have had loss of income. And so having to deal with all of these things along with pregnancy is rather challenging for the pregnant women. So what is the effect of COVID-19 on pregnancy? Pregnant women are not at an increased risk of contracting the infection than the general population, but they have an increased risk for severe disease than the non-pregnant population, and have worse outcomes. This, I think many of us have come to accept. In the earlier studies that were done, the emphasis was that the risk of contracting the disease is not higher, but now with more evidence, especially also from low and middle income countries, there's enough evidence to show that severity is the bigger concern amongst pregnant women, and that they are in fact a high risk group. Majority of the pregnant women that you'll see will be asymptomatic, but those who develop the disease will have got a high, but those whose disease progresses might have increased risk for severity and maternal mortality. And so and this is why it's concerning, because it's understanding how the disease gets worse, or the life of the disease itself. Severe illness is more common in the third trimester. And so there's enough studies, including the UCOS study, which was well known, which highlights that disease severity is more in the third trimester. What are the risk factors for admission with COVID-19 disease? It's minority groups, it's Black women, it's Asian women who have a higher risk of admission, who have a higher risk of maternal mortality, of admission to ICUs. And so it's important to note this, because if you look at studies done in some parts of the world, particularly in high income countries, you might find that the studies are not finding similar findings. But when we look at our South African population, we know that as majority of our patients may fall into the Black and Asian group, that they have got a higher risk for admission and adverse outcomes. Women who've got a BMI of more than 25 have got an increased risk of admission. Pre-pregnancy comorbidity, particularly diabetes and chronic hypertension, have got an increased risk, and maternal age of more than 35 also have got an increased risk. So if we look at transmission now, going into the three areas that I said I'd focus on, which was transmission starting off. And so very early in the disease, our main concern, our main questions were around vertical transmission. And just like in any infection that affects pregnant women, the mother-to-child transmission is often what we want to understand. And so interesting studies were done looking at vertical transmission in the amniotic fluid, cord blood, neonatal throat, breast milk. And in the beginning, and this was around the time of the first wave in many countries, there wasn't evidence of vertical transmission. But that was right at the beginning of the disease. And so as I talk, I'll also talk about some of the evolutions that we have found as we've studied the disease further. Now, if you look at more recent evidence, and this was a paper that was published in Nature, some of the perinatal transmission has been described, but there's no clear consensus on whether it's transplacental, it's transcervical, or whether it's environmental. And so in the few case studies or case reports that have been done, there has been the question around, is this in the placenta, or is it transcervical, or is it babies that were born negative but became positive within the first day or two of life because of what they were exposed to in the neonatal settings. And so this has been quite interesting to follow, but I don't think we have concrete answers on this. What we know is that there is some perinatal transmission, and we have to be careful because we don't really or fully understand the nature of the transmission. Some of the work that was done initially, and as I mentioned earlier, because of the findings that a lot of the women may be asymptomatic, and there was initially a call for asymptomatic screening to test and to try and ensure that every woman that is pregnant gets tested. And again, you need to weigh the benefits. It needs to be cost effective, and so in some settings it might be that it is affordable to test every pregnant woman, but in other settings it isn't. And so as recommendations and guidelines are made, they might differ by region, by country, by setting as well, based on the resources that are available. And then we also wrote this paper on the judicious use of PPE. And this was really sparked by an outbreak of COVID-19, which was in KwaZulu-Natal, which resulted in a number of doctors or healthcare workers dying from COVID-19. And so what we realized at that point was that, the importance of having enough PPE available for healthcare workers, and also preventing the spread of the disease in maternity units, because what you don't want is the maternity unit to become a source of infection or spreading infection. And so at this point, this was towards the end of last year, we also included some recommendations for the infection and prevention control in maternity units for South Africa. And so again, I'm just showing you the evolution of how things have changed rapidly over possibly around an 18-month period in us understanding the disease. So if we move to outcomes and trying to understand the outcomes of pregnant women with COVID-19, there have been a lot of disruptions to universal health services. And I think this really pinpoints, the core of what I want to talk about when it comes to outcomes, because pregnancy-related outcomes are not only related to the infection, but are also related to access to healthcare during this time. And so we're all quite familiar with the disruptions, the lockdowns, and what has this meant for pregnant women? As I said earlier, when pregnant women don't know whether they should attend antenatal clinic or not, should they rush to hospital or not, if they feel they've suspect that they might be infected, should they stay at home or not, the use of telemedicine and other sources to try and reduce patient contact, what has been the end result for this in this vulnerable population of pregnant women. And so it's important to understand the big picture, because it's not only about the clinical care that we offer to the women when they are sick and when they're in hospital, but it's also what healthcare prevention, promotion, education that we provide, and also what messaging we provide as advocates for women's health. And so these disruptions have really had a bad impact or effect on pregnancy outcomes in mainly low and middle income countries. And so it's important that we understand this and pay attention to this, that it's not just the pregnant woman with the disease who's at risk, but it's also the pregnant woman who doesn't have the disease, who might be at risk of not receiving the care that they should be receiving. And then, as I've mentioned before, the severity of disease in the pregnant women compared to the non-pregnant population. So as mentioned, and I think one of the biggest studies that was done on this was done by the CDC, looking at women who are pregnant compared to women who are not pregnant of the same age. And what they found is that women who are pregnant are at higher risk of hospitalization and severe disease than women the same age who are not pregnant. And that rates of severe illness and deaths are also higher in certain racial and minority groups. And so again, this is what we should always remember, because this will also determine how quickly we act and how we advocate for women. Some of the outcomes that have been discussed or presented is increased preterm birth related to COVID-19 and cesarean section deliveries. So we now know that pregnant women with COVID-19 have got a higher chance of having preterm birth and had delivering by cesarean section. The reasons may not be clearly understood, especially with the preterm birth physiologically or pathologically, but we are aware that that there are perinatal outcomes that we need to pay attention to. But in certain populations, at the same time, especially in high-income countries, there are settings where they found reduced preterm birth in the general population by up to 10%. And this has been, or some of the hypothesis behind this has been, women who've been, working from home, having more time to rest and look after themselves during the pandemic, and some of them and not having some of the strains that are associated with, going to work every day and being busy. So it also shows you that we are seeing different outcomes, and we're seeing different pictures in different parts of the world. But as South Africa, we should always be mindful that more of the patients that we see, particularly in the public sector, are going to be those who experience what we've seen in other low and middle income countries. And so an interesting finding as well was on ectopic pregnancies, that there's been an increase sixfold in women requiring surgery for ectopic pregnancy. And this is important because it's highlighting some of the challenges and issues with early pregnancy, which includes the delays in diagnosing pregnancy, the delays in the management of pregnancy, particularly because of women being afraid to access healthcare services, looking for care during this time. And so a woman might not readily go and do a pregnancy test, for example, because of the fears, the lockdowns, the anxiety, and everything that's happening around us. But this has resulted in some or in more complications than usual related to early pregnancy. Maternal mortality, there's been increased maternal mortality rates in low and middle income countries. And in South Africa, the maternal mortality has went up by 40%. And this has been well documented, and this has been published and looked at as well. And so this highlights exactly what I've been saying or trying to highlight, that the adverse outcomes affect everyone. When women are not able to get the reproductive services that they would normally get, this results in an increased maternal mortality rate. This results in increased pregnancy complications in early pregnancy. And so as obstetricians and gynecologists, as healthcare workers who look after pregnant women, we should need to be mindful and look at the entire population, because it is a vulnerable group or high-risk group, not only because of the disease, but because of the pandemic as a whole. This was a paper that we published in the Lancet looking at stillbirths and advocating for the counting of stillbirths. We know that stillbirth rates, especially in many parts of Africa, are not routinely counted or recorded or reported. In some countries, we've relied on statistical modeling to understand the stillbirth rates. But I think what is even more evident is that if we are not counting at this time, we risk thinking that women are okay, that women are having outcomes, normal perinatal outcomes, and when our stillbirth rates might have gone up. So I don't really know what the perinatal mortality rates are in South Africa at this point. Very few countries have actually highlighted that, but it's important that whilst we are reporting that maternal mortality rates have gone up, that we need to also report on stillbirth rates and perinatal outcomes during this time. So maternal mental health has also been a very important issue that needs attention. And I've already highlighted this in the beginning, but what I really want to touch on is just affirming or confirming that there's increased risk for postnatal depression, increased maternal anxiety. The limited companions, no family visits also mean that women are more likely to develop maternal mental health issues, disorders during this time. The limited interaction between patients and the hospital staff, even during this time. And so whilst everyone is wanting or has to protect themselves from the disease, it can also create a very lonely environment for pregnant women, where they feel isolated, feel that they're on their own, even within a hospital setting. And so we need to find ways of making these labor wards, maternity units, friendlier places, creating more ways for more support for women and for families during this time, because it really is a difficult time where people are not able to engage socially as they always have in the past. And then there is a social stigma and isolation. If you hear that a woman, or for families, that if a woman happens to have COVID-19 during pregnancy, has got a child, has the baby, there's even after they've recovered, but the chance of receiving the family support is even worse. So we need to just think about the women and have a patient-centered approach as we look after pregnant women. So the last part that I'm going to go into is the evolution of science during this time, and just highlighting the journey that we've been on as scientists, as healthcare workers, as clinicians, who have been following all the information on pregnancy related to COVID-19. And as I said, we started off with mother-to-child transmission, and the immediate concern was, is there transmission from the mother to child? We started looking at pregnancy outcomes, and even the journey of understanding pregnancy outcomes has also evolved with time, because what we thought in the beginning, when we still had early data from some high-income countries, is very different from what we were seeing towards the end of last year, when we started having bigger studies from more countries and from different parts of the world. There were the questions on breastfeeding and pregnancy, and it was established that it's safe to breastfeed during pregnancy. There were questions around routine testing, and that, with care, it needs to be context specific, and perhaps even the question around the partner, whether the partner should test before he comes, if he's going to be present in the hospital during the delivery. And I think many centers have advocated for that or require that. But it has to be very context specific, and so and following the national and international guidelines that are available. Mental health and pregnancy, I've spoken about that, and more research needs to be done, and we need to understand it from an evidence perspective and not only from the interactions that we have with individuals. Vaccination in pregnancy, a lot has been done here, and I'm going to touch on it shortly. And then looking at maternal mortality and stillbirth rates for the pregnant population. And so it's quite clear, I believe, that we've had increased pregnancy adverse outcomes, I think, internationally. In South Africa, definitely related to the pandemic, not just related to COVID-19, but specifically related to how the pandemic has influenced pregnancy and pregnancy outcomes. And then health system strengthening and policy is a new area that we need to start looking at and understanding. And my work is more looking in this area and trying to understand how can we create policies that will better facilitate the management of women who are pregnant, who experience the disease, and are there certain things that we can do to strengthen the health system in order to improve the outcomes of women who are pregnant. And so we need to evolve as the research evolves and as the science evolves. We also need to look at how the policies are evolving and what policies will better suit pregnant women. So when we look at vaccinations, the available data does not indicate any safety concerns or harm to pregnancy, and vaccinations should be considered where the risk to exposure is high and cannot be avoided. And this is part of the RCOG guidelines and many of the pregnancy-related guidelines that we follow recommend vaccination in pregnancy. And it's important that we also, as healthcare workers, provide this information to our patients and are available to give them the required evidence. Of course, the initial or concerns with vaccinations is that the vaccinations were not tested on pregnant women. The trials were not done on pregnant women. But since vaccination started being rolled out and used in many parts of the world, there's enough evidence to show that pregnant women have been safe who have been vaccinated. I want to touch on the health system factors because I think it's important for us to look at health system factors and not only look at the clinical factors of the disease, but looking at why do certain women have increased risk of death, of being admitted to an ICU. And so it's important that we try and look at it from the delays and understand the delays that women might experience, especially during a peak or during a wave where everyone is competing for hospital beds, where there's an increased number of people that are infected. And so there isn't enough resources or facilities to care for those who have the disease. And so we might have issues with delayed diagnosis, not monitoring the women as they should be monitored, not being able to provide the beds, ICU beds, ventilators, oxygen. And so whilst we may understand the clinical implications of the disease, we also need to understand the health system implications of the disease. And we should be able to provide, to try and strengthen our health systems so that women are able to receive the care that they require when they need it. And so I was part of the South African COVID-19 study, maternal and perinatal outcomes of the novel coronavirus in pregnancy, with co-investigators or co-PIs, Dr. Samantha Budram, Dr. Valerie Fenefel, and Dr. Laura Yates. And so this was a national study which we did in multiple sites, funded by the South African Medical Research Council. We've done the study in 6 provinces with over 36 study sites. We in the process of publishing the first paper, which reports on the first 680 cases that we saw, or forms that were received, of 680 women across the country. And we've also collected data during the second and third wave, and we'll continue to try and get this work published and reported. But the main key findings in the South African study was that the majority of the women were infected in the 3rd trimester of pregnancy. The most common comorbidities that were seen were HIV infection and hypertension. We had a high preterm birth rate and cesarean section delivery rate. 1 in 6 women required ICU admission, and 1 in 16 women died. And that was a case fatality rate of 6.3% and a stillbirth rate of 4.7%. And these were all women who had COVID-19 or were diagnosed with COVID-19 during pregnancy. And so the findings that we found in South Africa, of course, there's more data than this. This is a summary just to show some of the work that we have also done here. But the findings, what we found is very similar to what has been reported in many parts of the world. And so the study does confirm many of the things that we have seen or that have been shown in low and middle income countries, also highlighting the fact that pregnant women need to be looked after carefully if they develop COVID-19 in pregnancy. The mortality rate was higher than expected, and the ICU admission rate and mechanical ventilation rate was higher than expected in this population, also affirming what we have seen in other parts of the world. So in closing, I'm going to just go through a few recommendations. And I think the biggest fear and concern is the notion of COVID orphans. If women are dying and it's going unnoticed, if pregnant women are having adverse outcomes and it's not being noticed by the world, by the country, that leaves us with problems that might take decades to recover from. A lot of the work on the Sustainable Development Goals, a lot of the work towards improving maternal care, just through the pandemic could be reversed. I think, as I highlighted, the maternal mortality rate in South Africa has already gone up, and this has been years, decades of trying to reduce it. And so we really don't know what the future holds for us in terms of this work, but there is an important need to ensure that maternal care is strengthened during this time, that COVID-19 disease is prevented, particularly in pregnant women, and that women who are pregnant who have the disease receive the highest level of care. And so on a health systems front, it's improving patient education and advocacy for pregnant women, improving the availability of PPE and ensuring that there's judicious use, and then strengthening the critical services and management of critically ill patients, knowing that a certain proportion of women might become critically ill. And when they do, we need to be ready as a healthcare system to look after them. And then the recommendation on vaccinations in South Africa, the recommendation is that pregnant women should be vaccinated. Reproductive aged women who are should be vaccinated. even if they are planning to conceive. Those who are pregnant should be vaccinated from 14 weeks onwards, and women who are breastfeeding should vaccinate as well. And the two vaccines that have been recommended are Johnson & Johnson and Pfizer. So in conclusion, I really just want to emphasize and highlight that, that we've probably come a long way, or the world has come a long way in understanding COVID-19 disease in pregnancy. And rapidly over the past year and a half, there's been a lot of research that has been done, not only in high-income countries, in low and middle-income countries, and in South Africa as well. We've been part of we've also contributed to the research that has been done on this. We've also contributed to the advocacy that has been done by drawing different levels of evidence and trying to put together national guidelines, putting together sound information for clinicians, for frontliners, for everyone who is part of looking after the pregnant population. That pregnancy is terrifying during a pandemic. It's not just about the disease. It's really thinking about the pandemic as a whole and trying to understand what the implications are for our patients. So in conclusion, I would encourage all of us to find ways of strengthening our health system or improving healthcare for those in our system, wherever we are, our ecosystem, wherever you are. Let's do our bit to improve care for those that we look after. Let's protect ourselves as well from the disease as we look after women. Let's ensure that the pregnancy experience still remains positive, despite all the health hurdles and difficulties that pregnant women may face during this time. Thank you very much for this time, for inviting me, and for taking time to listen to my talk. Thank you.